Good morning, everyone. And welcome to the 2022 Reaching Out From Within Symposium. I would say annual symposium, but because of COVID the last 2 years, it's 2 years late. So this was supposed to be the 2020 symposium that we're having this year, but hopefully we will have those as annual events moving forward. I am Greg Winship, and I am the MC for today's event. I serve as a member of the board of directors, a past president, but maybe more importantly, a mentor and a volunteer for the Reaching Out From Within members. I am so excited today to welcome you to such an influential gathering of people discussing such an essential topic, rethinking human dignity in our criminal justice system. Before we begin our event, I'd like to take a few moments to recognize some of the people who made this event possible. Joe Scoville serves as the chair of the Symposium Committee this year. Joe, would you please stand? And the other members of the committee are listed in your program, but could we have the members of the committee also stand? Thank you for your service. We also have a number of Reaching Out From Within board members and staff here today. I'd like to recognize Kiki Huggins as our board chair. Would other members of the board please stand? I'd also like to introduce you to Jim Eccles, our executive director. Jim, I'm not sure which table you're at. There you are. And a couple of our staff members, Sarah Hartweir. Sarah, are you in the room? And she might be running around out here. And Richard Thompson is in the back. He is going to be helping with our internet connections today. Finally, we have some volunteers, Reaching Out From Within volunteers and alumni in the room. Would you please also stand? Leslie Leahy provided all the table arrangements today. Leslie, thank you for all the work that you do for Reaching Out From Within. We are grateful to the symposium donors, which are also listed in your program, but I also want to acknowledge two longtime supporters of Reaching Out From Within, the Kemper Family Foundation at UMB, as well as the Bob Barker Foundation, and they're both represented in the room today, so give them a round of applause. And the list goes on, but finally I'd like to recognize Carrie Hartnett. She's in the back of the room. Most of you know her. She is the symposium event coordinator. Carrie, we thank you for your efforts today in putting this all together. And there were many, many more people behind the scenes, so I'd like to thank everyone that made this day possible with their dedication and hard work to bring this event together. For what I know will be a meaningful conversation as we move through the day. Reaching Out From Within is a Kansas-based nonprofit organization that sponsors 19 self-help groups in every prison in the Kansas Department of Corrections, one group in the Federal Bureau of Prisons at USP Leavenworth, and currently 3 groups at the North Carolina Department of Public Safety. Next month, actually in a few weeks, we plan to open our first group in the Missouri Department of Corrections and start a second group shortly after that. During the weekly meetings, Reaching Out From Within members facilitate a discussion of one of the 9 units in our 400-page Blue Book curriculum. This book will be out of the front table after these remarks, so you can take a look at the Blue Book and examine the curriculum. The mission of Reaching Out From Within is to inspire and support incarcerated individuals to find the courage to change and become self-reliant and productive returning citizens who contribute to the betterment of our communities. Each of our Reaching Out From Within groups begin every meeting with a moment of silence for victims of harm and violence. Would you please join me in taking a moment of silence for those who have been harmed? Thank you. One of the other items that every meeting starts with is a positive thought. And Leslie, in just a minute, we'll have the jar in the back, but we've invited you to take a positive thought out of the jar, and I'm going to share the one that I grabbed this morning. Don't be afraid to start over. It's a new chance to rebuild what you want. Anybody else have one that they grabbed this morning that they'd like to share? Yes. Very good. Anybody else? Yes. Go ahead, Anna. Thank you very much. Would you take just 10 seconds and share a positive thought with somebody at your table next to you? Thank you for sharing. Today, we have nearly 200 people in the room with us in person, and probably that many more that will be joining us online. We welcome to all of you watching virtually today in other parts of the nation. Please let us use the chat feature to communicate with us. Richard Thompson, our staff member in the back of the room, will be moderating the chat throughout the day and can relay any questions you have for us. You will be able to participate in the Q&A and the discussions. We hope to be able to make that interactive. So we have a number of prisons, Missouri, Kansas, North Carolina, Nebraska, all have staff and or residents watching this event today. So give them a hand. It's now my distinct honor to introduce someone who needs no introduction in this circle, Sue Ellen Freed. She is the co-founder of Reaching Out From Within. In 1982, Greg Musselman asked Sue Ellen to meet with the members of the Lifers Group at the Kansas State Penitentiary. They wanted to know how they could help stop the violence in their community. I would need another 30 minutes to describe just some of the ways Sue Ellen has influenced the men and women whose lives have been intertwined with the criminal justice system. Suffice it to say, for 40 years, Sue Ellen has been a leader and an impassioned advocate for those on the inside. This fall, Reaching Out From Within will honor Sue Ellen and the men and women who have been a part of the Reaching Out From Within journey as we celebrate the 40th anniversary. Please welcome Sue Ellen Freed.
Thank you. Can you hear me? Thank you. I can see you, and if you can hear me, we're a good partnership. I think it was about 7 or 8 years ago, I was watching 60 Minutes on Sunday evenings, and they were interviewing the head of a prison in Germany. And he was describing what their prison system is like. The day you come into the prison, you are assigned a team, especially a social worker, who will be monitoring your journey to help you prepare for a successful re-entry to the community. That is the goal that starts the day you enter the prison. The people who come in wear their own clothing. They have their own bedroom with their own key. They want to normalize your life while you're in prison so that when you go out, it's not like Rip Van Winkle, and you try to adjust to a world that you're not familiar with. They took me to the dorm where they live. At one end of the hall is a mini kitchen. They want you to learn how to prepare your meals so that you will be ready to be productive. They even have little mini refrigerators, so if you have leftovers, you know how to learn to cook leftover meals. This social worker that is assigned to you will be witnessing your journey while you're inside a prison, your transformation, and will be making a major decision about when you get released because they know so much about you. None of the staff at the prison carry weapons. The head of the prison who gave me his card when I left, it said Axel Bremley, social pedagogue. The staff are all members of the pedagogical team. The incentive to follow all the rules, to choose from 5 careers that you can get trained for while you're still inside, and the incentive is how much time your family gets to come and spend with you. It was so mind-boggling to see a system that has been in place since 1977. This is not a new fantastical idea. This is the way the German prison system operates. So when we had our first symposium 3 years ago, we brought Axel Brumley, the social pedagogue, to come here and speak to you. Reaching Out from Within believes that this country is beginning to take some of those ideas, some of that energy, and bring it to this country. And today is going to be a day to try to highlight all the energy that is going on in the United States to bring us to a life of excitement and transformation that is happening in this country. So we are going to be hosting this symposium every year to recognize and show our gratitude for efforts that are going to be rethinking human dignity. Thank you for being here to be part of this exciting journey, because criminal justice reform is a social movement whose time has come. Thank you for being part of it.
So let's get this program underway. The first panel members can go ahead and take their places up here. I'd like to introduce Michelle Irwin, who is from First Call KC. She will be the moderator for this event. So panel members.
Good morning. I think it's on. Yeah. Good morning again. My name is Michelle Irwin, and I'm the Community Outreach Specialist with First Call, Alcohol, Drug Prevention, and Recovery. We are a local nonprofit that provides a full continuum of care around substance use disorder in the metropolitan area, and we've been doing it for over 60 years now. I'm grateful that I get to be the moderator for today's first panel, and we are going to be discussing overuse in the criminal justice system and reducing incarceration through treatment as an alternative. And I will allow the panel members to introduce themselves, and then we will get started with this conversation.
Good morning, I'm Chris Rochelle. I handle all the referrals and intakes for the reentry program for First Call in Kansas City, Missouri.
My name's Annie Pankratz. I am a nurse practitioner with the Colorado Department of Corrections.
I'm Andy Civils. I'm a medical student at UMKC, and I focus on addiction research.
I'm Michael Gibbons. I'm a retired KDOC as well, correctional person. Thank you.
Keith Faison, wow. Keith Faison with First Call Reentry Team Lead.
Steve Howe, Johnson County District Attorney.
Great. Thank you very much. We will start our conversation, and I ask that we wait to the end for any questions. We will have a Q&A at the end for about 15 minutes with questions. So let's get started. Let's start with you, Mike. Welcome.
Thank you.
Why don't you share with us your experience with the substance use disorders and mental health treatment in the criminal justice system?
I can relay back to when I was a parole officer. We had dual diagnosed individuals that were out on the streets, and it was very difficult to be able to contend with anything that was happening with them because there wasn't enough resources for them. And unfortunately, usually they'd end up back inside the institution. Now, inside the institution where I had worked up in Lansing Correctional Facility, we have what they call our TRUE units. And those are specifically designed for the mental health individuals. They have a TRUE 1, TRUE 2. Depending on the severity of the individual that has the mental health issues going on, it determines which little facility they're in. Basically, they try to divide them away from the general population because of the issues that they have versus the general population individuals that unfortunately can harm or manipulate the mental health guys. And one thing that's been strived that's been happening in the mental health field, as you well know, is that there's been an extremely large amount of people that are experiencing mental health issues, even more so than ever before. And one of the things that we've looked at and discussed is why are they coming in and what needs to be done. And unfortunately, sometimes they end up coming into the Department of Corrections with these mental health issues as well as drug issues. And we have talked about, okay, what happens in there? Well, inside, they get a lot of good advantage of programs. They have counselors now that are working with them to be able to address their needs as well as looking into their drug issues as well. The unfortunate thing is that's inside. And so when you're in a controlled environment, it's not a problem on being able to control the individuals that are inside, because they can get their medication, they can do their programming, they've got counselors to deal with, they have those things. The issue or the problem is when they go back out. And when they go back out, one of the problems that exists is not only getting their medication correct, but the actual treatment facilities that are available to them on the street. They had to learn how to live inside. And now they've got to go back out to where they were at, where they had the initial problem. And if they had dual diagnosis where they had the drug issue, if you remove the drugs, obviously you're dealing with now just a mental health issue. And so when we think about treatment versus incarceration, one of the things that some of the individuals that are in here that have been released, they can tell you when you come outside of the institution, it's just like going to the moon. It's like when they came in. They didn't have an understanding, now they've gone out. Imagine having the mental health issues where you were in a controlled environment where you had food, shelter, people talking with you, and you're getting your medication. Now you're being released. The thing that we've looked at is maybe we ought to take a look at why they have come inside the institution and why that has happened through their mental health issues. Obviously, drugs change a person's whole thought process, which we'll address that as well. But one of the things we're looking at and want to address with the folks that are out there now is that maybe we ought to take a look at the individual and see what their actual mental health state is and address them on the street where they're coming back out to. That's where the issue lies. Inside, general public generally don't care about what happens inside of an institution. They really don't want to know about what goes inside. They just want to make sure that we keep them incarcerated. But the problem is when they come on out on the outside, then they take a dim view at parole officers, probation officers, the police, and everything else because they decide that they're not helping the mental health individuals that are acting out and having the issues. So one of the things that, is that if we go to where they're at and we begin to deal with them at that level before they're incarcerated, because one of the unfortunate things that happened in Kansas is we closed most of our mental health facilities. So that ended up being a dump site for them to come into DOC. And then DOC had to make some changes to be able to make that arrangement because at first they came in and they were just in general population, which was pretty crazy. That's why the TRUE units and different units throughout the state of Kansas that I'm speaking to have developed a programs to be able to get these guys where they can be able to at least stay inside the institution and prepare to go on to the outside. But that preparation is okay, but the real deal is once they hit the street. And once they hit the street, that is where the issue becomes a community problem. And that's one of the reasons why I'm up here, is because I'm part of the community just like you. And I decided that maybe we need to step up and see what we can do for individuals prior to them being incarcerated and deal with just strictly what their issue is to begin with. And if it's being a mental health issue, we need to deal with that. We need to actually have programs and things that are in order to be able to address those issues before they go in and become incarcerated. Because unfortunately, a lot of them come back that are incarcerated. And you think about it, their security is inside the institution. All of you that have been inside institutions, you understand it's a person that's institutionalized. Sometimes it's a lot better for them to come back because it's a secure place. And they got a place to live, they got food, they got all that, it's fine. But when they come out, they don't have all that. And especially if you have mental health issues on top of that, that is where the issue lies for us as a community, to where we need to start putting things together to where we have organizations to address their needs on the outs before they come to the institution. Because once they're released, there's a very high recidivism rate of them returning because they go back to their old habits. They're scared. They don't have a place to live, or they don't have they run out of their medication, or they get back to the street and they start drinking and adding their medication on top of it, and then they're totally out of control, and the only time they get back in control is when they come back inside the institution. So one of the things that we need to take a look at as a community is what do we need to do to address the mental health issues prior to locking up an individual? Because once you lock them up, then it's a whole different game trying to get them out. Thank you.
Thank you, Mike. That's great. And Mike did bring up a good point. You know, of the drug offenders that are incarcerated and then released, 68% of them are back in jail within 3 years. So being able to address that and lower that number is what we're trying to work on today. Keith, why don't you share with us your experience?
Yes, good morning. I like what my co-part said, that we work with municipal court, drug court. So we have an advantage. I've been in the field working with Department of Corrections treatment close to 30 years, so I have a real passion for it. I guess the sadness of it, what we do first is a client is screened from the court and recommended for drug court. I then set up and do a biopsychosocial full drug and alcohol assessment. Not only am I looking at their drug and alcohol history, methamphetamine is on the rise, cocaine, marijuana, opiates. I have to take a comprehensive look at their mental health. So mental health is the issue that we struggle with too. So when mental health is identified, unfortunately, with low staff in the jails, mental health doesn't always get addressed. By the time the client lands, either they have been seen by a mental health or they meet one of our recovery advocates, reentry advocates. We start that whole process. They do land into a transitional living, so their housing needs are taken care of. They start a outpatient program, so they start the alcohol and drug treatment. But then we start looking at, okay, let's get this client stable. And so some of the times what we run into is trying to find proper ID, depending on the zip code they're from, the severity of their mental health. And so we're trying to look for programs that will help that client start the process. sometimes, or worst case scenarios, what we go through is by the time the client is finished with a 28-day program, the client can either just start getting stable or we're still working on it. And so I think what we are asking for is select programs that will work with offenders that don't have proper ID, that don't meet criteria for emergency mental health services. Because an inmate that gets out and doesn't have mental health services, that is a crisis for the community. Now, our numbers stay pretty steady. Drug court gave me their statistics, and out of, I believe, 68 clients that they served over last year, 50% return back to jail. What we're looking at, our advocates really are trained in looking at, let's get this client stable in the first 90 days. It's vital. If we can't get them stable in that first 90 days, it's very likely that they can return. So the terminology we use is high risk, high need. High risk, high need. That first 90 days is vital. And as many of you know, what they're really going through is adjustment disorder. How do I readjust outside of the institution or the jails? Fortunately, our advocates are there with them, walking them through. We have to get the clothing. We have to get ID. We have to get other emergency issues that they need at that particular time, all the while trying to make sure that they go to treatment, and all the while trying to make sure that they're taking their medications. Now, the tough thing is some inmates don't like medications. They haven't had the right medication regimen. And so that's another thing we fall into, waiting on the client or waiting on trying to find a good mix where the client can feel comfortable taking those medications. So our numbers, however, for first call, we're at 71% of serving clients not only with municipal court, but in prisons as well. So we get clients not only from municipal court, but we also get clients releasing from prisons. So we start that relationship early, and that's where we're most successful. If we can start that pre-release relationship and rapport, then we stand a better chance. But I can't overemphasize it. I think we all struggle with the barrier of mental health services and COVID issues as far as staffings in the jails, because you just don't have enough staff. You don't have enough mental health staff, and so you run into this COVID thing that you just don't have enough people on staff to meet the need, even while they're incarcerated. So, thank you.
Thank you, Keith. Thank you for that information. Chris, why don't you elaborate on this?
Sure. Thanks, Michelle. And thanks so much for putting this symposium on and highlighting this idea of dignity. You know, people who are incarcerated are people who are incarcerated. You know, we try to use person-first language because these are people and they deserve dignity. They don't deserve dignity. They have dignity inherent to being human, right? And so I have 6 minutes. Sorry, I was supposed to look at my watch. And I'm going to try to take less than 6 minutes because Annie is going to share next, spoiler alert. And she's brilliant, and she has a lot of really important things to say. And so the National Institute of Drug Abuse, which I try to, okay, I don't need to explain myself. They estimate that 65% of incarcerated people are experiencing substance use disorder right now. That's an estimate, right? That's pretty astounding. Over half, like significantly over half of these people are experiencing substance use disorder, which you know, the very smart people have deemed as a disease the APA, the AMA, all of those things. So we're like, these people are incarcerated because of crimes most likely peripheral to a disease that they have, which is astounding to me. So this idea of treatment rather than incarceration shouldn't be like groundbreaking, and yet it is. So if we just take a look, I'm not gonna tell you guys anything you probably don't already know. Unfortunately, it's a really sad system. I don't wanna leave my little talk on like a bummer note, but you know, as Mike and Keith were talking about, these barriers are huge for people exiting this carceral system. So we talk about risk factors and we talk about protective factors. And what's interesting is if we look at risk factors that are putting people at a higher likelihood of experiencing substance use disorder, they're extremely similar. There's a lot of crossover with the same risk factors that are that increase the likelihood of someone becoming incarcerated. I've written down a couple because I don't remember things very well. Mental health diagnoses, community violence, so just where you were born and growing up, history of family history of mental health and family history of substance use disorder, higher ACEs scores, so that's the Adverse Childhood Experiences test, which I'm sure many of you are familiar with, and then just lower socioeconomic status, right? These are all like kind of like givens that we know, but that should be highlighted because these are like systemic issues which put people at a higher risk of incarceration and substance use disorder. Fortunately, there are protective factors, right? Protective factors are just things that are decreasing the likelihood that someone's going to experience substance use disorder or incarceration. And the crossover there, again, is shockingly similar. So some things are stable housing, meaningful and gainful employment, all right? So that someone actually likes their job, wants to show up to work, and can put away a little bit of money. Education, higher education, and then positive social supports. All of those things are gonna decrease the likelihood that someone is going to experience substance use disorder and incarceration. And so Annie and I were talking a little bit, and Mike mentioned it this morning, about just how inside of this carceral system, a lot of the barriers to access for those things are removed. And then they are placed back in place once someone exits this carceral system, right? So they're able to access maybe some mental health care. They're able to access treatment. They can get a job without having to get, having to come up with $15 and a good enough story to get a birth certificate so that they can, you know, come up with $20 more and make an appointment with the Social Security office to get a Social Security card so that they can obtain an ID, so that they can go get a job, all of which they need money for, they need rides for, and someone just needs to take them at their word that they are who they are. Yeah, inside you can just get a job, go, you know, start working, you know, build that social, that community, that have some of those positive social supports. And so all of those things are stripped away when you exit that system, so I was on a webinar, I don't know, a few weeks ago, and what I heard was someone who's exiting the carceral system is at a 14 times higher, the likelihood of them overdosing on opioids is 14 times higher than anyone else. And then I was like, oh, that's a pretty cool fact. I mean, not a cool fact, but that's an interesting fact. Let me Google it real quick. So I misheard, it's a 40 times. They are 40 times more likely to overdose on opioids than someone else, someone who's not exiting that carceral system. They did a study in North Carolina about that. So I'm out of time, but there are things that can be done. These are systemic problems. They require systemic solutions. We need to rethink this entire system. You guys are already on board, I'm sure. So I'm kind of preaching to the choir here, but it's exciting that we're here talking about this and kind of ground level addressing this issue that people involved in this carceral system are people who are inherently valuable and deserve dignity. So.
Thank you very much, Chris. And Annie?
So as a medical provider with the Colorado Department of Corrections, I want to let you in on a secret. So when you go see your family doctor, your primary care provider on the outside or on the inside, we are compiling this fancy, clean list of medical diagnoses when we see you. So that it could be anything from malignant neoplasm of the gastrointestinal tract to something as simple as foot pain. And so there's a set list of thousands of understood medical diagnoses. And drug use, opioid use, methamphetamine use, those are all medical diagnoses. And of the thousands of medical diagnoses that we can choose from, those are the only ones that are also crimes. And right now, kind of the problem that we're dealing with is that the system, policy, finances, it is all focused on those medical diagnoses being crimes and not medical diagnoses that they are. And the Colorado Department of Corrections, we're really focused on the medical diagnoses of drug use. So just like many other departments, we have a medication-assisted treatment program within the department. And as part of that, the residents or the patients receive medications like Suboxone, methadone, naltrexone to help treat those use disorders. And alongside that, of course, they are also set up to see drug and alcohol specialists, mental health specialists, kind of a holistic treatment of that. But, and I can kind of tell a really quick example to drive this point home, but that's definitely a process. And a lot of people are not incarcerated long enough to go through that process. So I had a patient just recently who came in and he had an opioid use disorder but was not in the MAT program, was not on Suboxone. And he said, I'm literally getting out in 10 days and I can tell you I will walk out that door and use fentanyl. And that was I like to say my spidey senses were activated. I was really concerned about this one. And so we have a MAT physician, which is awesome that we have her. And she told me that we actually have this program called InReach. And as long as a medical provider has diagnosed them with opioid use disorder, they will not be released to the outside without being set up with a MAT provider on the outside. So they will, when they leave, they will have a prescription for Suboxone, an appointment with a MAT program waiting for them when they release, which is really important. And you know, when we were kind of preparing for this panel, I eventually said, gosh, it seems like we can talk a lot about how good we are at treating opioid use disorders on the inside and preparing them to releasing for the outside. But imagine if we could treat drug use disorders on the outside the way that we can on the inside, and Chris spoke to that quite a bit. And so we talk about the reaching out from within. We expect and we hope that the residents will have the courage to change. And we need to have the courage to change as well. And by that I mean policy change. And specifically, the state of Oregon in 2001, last year, they passed the Measure 110, decriminalizing drug use. And the really cool thing is if someone there is caught with opioids, methamphetamines, they don't get arrested anymore. They maybe get a $100 fine, or they can choose to get treated instead of having to pay that fine. And so that's taking the incarceration out of the medical diagnoses of drug use disorder. And the awesome thing is there is a bill that has been introduced in Congress. So on a federal level, the Drug Policy Reform Act, so Drug Policy Reform Act for you all taking notes out there, just introduced to Congress. And again, on the federal level, that would be shifting the focus from drug use as a crime that is deserving of punishment to a medical diagnosis that is deserving of treatment. And so that's the direction I hope we can get to here.
Thank you very much. Thank you very much. Let's continue this conversation, Andy.
Again, thanks for putting on such a wonderful symposium with such an important purpose. And I think what I can speak to is a little bit of the pathology from a neurological perspective. Because I think the policies that we end up selecting should be informed by the science of the disease that we're hopefully going to treat. And so you might not know, or maybe you do know, that addiction really focuses in on the reward system in the brain. And so you could make it as complicated as you want, but we can really split it up into 3 separate pieces. And so at the top of this reward system is really the experience of being Andy. And what we know about that sort of higher level cognitive function is it really takes place in this part of the brain called the prefrontal cortex. And so that's just right there in the front. And then a second component of that system is sort of in the middle. It's called the nucleus accumbens, or in a greater range, we could call it the striatum. And so for the note takers, we'll do spelling afterwards. But that third piece is in the middle, and it's called the ventral tegmental area, and there's a second part called the substantia nigra. But these are where the rewards come from. And this is in a healthy person. Last night when we were here as a panel having some dinner, and I enjoyed my chicken, I got some dopamine in that VTA region from simply having that food. And if I were to have a successful panel and everybody has a great symposium, I'd get some for that too. But if I were to inject heroin before this panel, I would probably have 1,000 times that amount of dopamine that I could possibly not ever recreate. And so this old software, and when I mean old, I mean 300 million years back in the evolutionary tree, is being stimulated by these synthetic opiates and other kinds of drugs. That's where the disease of addiction or substance use disorders start to enter into the picture. And so what we know for sure now in the science community is that the reason it is a disease is because this reward pathway is hijacked by these substances. And even without the substance present, at the DNA level, these cells have been changed. And so if you have a person who's been sober 20, 30 years, they re-enter that substance into the same brain, they're going to end up having the same behavior they had in the first place. And so the question that's relevant to our talk today is that incarceration versus treatment, how do these affect this system? Do we have any evidence that treatment actually changes the neurological level of this problem? Do we have any evidence that incarceration either negatively or positively affects it? And the answer is yes, we do have that evidence. And so really just 2 years ago, in 2020, there was a study on an incarcerated population that looked at this exact reward center and cognitive function and found that simply as a result of being incarcerated, this group of individuals had a decrease in their cognitive function, which means when they enter back into the world, as Mike started off talking about, their ability to make those choices is already less than it was before they got there. And so we're not even helping these individuals. In some cases, we're actually putting them in a worse off place. And then a new study just 3 weeks ago actually is a randomized controlled trial that looked at this new system called MORE, which is mindfulness-oriented recovery enhancement, which is a very wordy way of trying to pull all the tools of treatment together and make them something that we can measure. And so in that randomized controlled trial, what they found is that those negative effects of incarceration were protected against by this MORE program. And at the actual cellular level, this nucleus accumbens that I talked about a little bit earlier has a decreased amount of activity as the result of treatment. And so if you're wanting to make a massive change at the societal level, you're going to hopefully want some evidence to support the direction you're going to go. And so when we have this data behind us and we're attempting to have the courage to change, then we can sort of muster that courage on the basis of science, in addition to our intuition that these people deserve more than simply being locked in a cage. They deserve to be treated for the medical illness that they have.
Thank you very much. What wonderful information we're getting from everyone. Steve, would you like to close it up?
Sure, and first of all, thank you for the opportunity to be here this morning. Michelle was smart enough to put the lawyer at the end so he doesn't take filibuster the entire event. So she was smart in that respect. I want to talk a little bit about what we've been doing in Johnson County, and it's really working. It's around our Criminal Justice Advisory Council, and if your jurisdiction doesn't have one, I'd highly recommend that you implement it. It's really a private-public partnership where we have public agencies like the Sheriff's Office, my office, Department of Corrections, the Johnson County Mental Health Department, along with citizens who strategize on things that we can do to make the criminal justice system work for our community. Because no matter where we come from, we all want the same thing. We want a safe community. And so how do we go about doing that? And you know, I've been a prosecutor for over 30 years, and I will tell you, my mindset has changed over the years. It used to be just lock them up, right? And I think a lot of prosecutors have realized that, you know, maybe there's a more efficient way of going about reducing recidivism in our criminal justice system. So the Criminal Justice Advisory Council, its strategy has been over the last 10 years of implementing programs from the very beginning, which is law enforcement interaction on the street, all the way through release through from the penitentiary. And so what I want to talk about is some of the things that we have implemented. First, on the law enforcement contact, we have now co-responders, which are Johnson County mental health workers, who can go out to the scene if an officer believes that someone is suffering from mental illness and try to triage that situation. That has had huge impacts in the number of people being booked into our county jail. And in fact, when the Olathe Police Department was the first one to do it, and they were so excited about that, they wanted to get 2. And then next thing you know, now it crosses the entire county, all the different departments. And so you had to break down barriers, because law enforcement was like, I don't need no social worker up here, you know, when I'm dealing with this. And what they found is it reduces the number of violent incidents they have with individuals who are suffering from mental illness and or drugs, and it also gets them the help that they need on the front end. Does it solve all the problems? No, but it significantly reduced the intakes into our jail, and so that was a very positive thing. The second component was, okay, if they're booked into jail, what do we do? And so we had the cooperation of the Sheriff's Office to do a little query of people in jail and asking them questions about, do you have some mental health issues, drug issues, and asking questions. Well, we did have a little pushback initially from our public defender's office, because they're like, well, we don't want them to make an admission. So what I did is I said, I am not going to use those against that individual. So that takes away that component and allowed them to be able to answer honest questions. And what we found was at least sometimes a little bit more than a third of the people that we were booking into jail had serious mental health or substance abuse issues. And we've all talked about coexisting situations with drugs and mental health. And so that allowed the mental health workers to interact with those people who are booked into our jail and trying to give them assistance, and also giving them their information when they do bond out of jail to come to the mental health department and get assistance. That also has been very instrumental in helping us reduce recidivism. And so the next component is, okay, so they're involved in the criminal justice system, what do we do with them? How do we reduce this recidivism? Well, one of the things we did a while back is we have mental health diversion in my office. And that is basically a partnership with our mental health department where they basically triage an individual and get them the assistance they need. So the whole diversion is based on them getting treatment. And one of the things that we have really backed away from is if you violate, you get put in jail. I mean, we pretty much understand that if you're suffering from significant mental health issues, you're going to mess up and you're going to have problems. And so it's not the first mistake, you're incarcerated. And so that's been another strategy that we continue to evolve and try to, again, partner with our mental health department. Another thing, we're very much blessed to have our residential center and our community corrections director, Robert Sullivan, in having a treatment center. Basically, it's a inpatient facility where if you walk away, it's basically walking away from the jail. but it gives people the ability to go out and do work, get their treatment, and so we've been using that as a component for low-level offenders, reducing or helping reduce recidivism and giving them the groundwork to be successful once they're released from incarceration. And then, of course, the final component, Robert has beds for the Department of Corrections, and so when they're getting close to the release, having them placed in there and getting them a job and giving them the foundation, as everyone's talked about, so that way they can be successful. Instead of saying, here is your paperwork and good luck to you, and realize that probably this person's going to have additional problems. So we've tried to triage it throughout the system. Are we perfect? No, but we have seen measurable decreases in our jail population as a result of these types of actions. The other thing is, the one positive thing I will say about COVID, and there's only one that I can think of, is that it forced our municipalities to stop booking all these people in jail and doing personal recognizance bonds because we didn't want to put all these new people in jail when COVID was active. We finally got the cities to buy in it. We've reduced those coming in for low-level offenses, and it stayed that way. So again, the one positive thing I can say about COVID is that it did change the mindset of many of our community leaders, and again, helping reduce the jail population. So I think through that kind of whole strategy from start to finish, we've been able to have some impact on recidivism and not impact our public safety in our community.
Thank you. Thank you very much, Steve. Well, thank you, everybody. I would like to thank again the panelists for their expertise and their experience in sharing it with us. And I was thinking, as I was listening, being able to have these conversations, being able to talk about these experiences and ideas brings them to life. And when we bring ideas to life, things happen. And that's how we can keep this going and make the changes that we need to make. Now we are open for questions and answers. Well, they'll give the answers, you give the questions. Anybody have any questions or anything they'd like to share with the panel? Yes.
There was a mention about public policy regarding the notion of people trusting in science. I found it interesting because a lot of people with even COVID don't really have a lot of trust in science. So how that to me seems like it would be a barrier in some sense. Getting everybody on board to speak the same language and have the same mindset, I think will be a difficult thing to accomplish, and our community will see it. Please repeat the question so
Okay.
everybody
Okay.
can hear what you said. Well, I was just saying that even with COVID and the research that's behind it, there's a lot of people that don't even want to trust in the science, right? Because we see the lack of people getting vaccinations. So I see that as a barrier when you talked about science.
Yeah.
And the ability for people to trust in the science, what you talked about, those 3 phases, which I think is absolutely wonderful. But I don't think people are going to buy in. And how do we change that mindset?
So I think it's an excellent question. And I think where COVID may have started in early 2020 or late 2019, the battle to hopefully treat substance use disorders on the understanding of science has been waged for thousands of years. So that's number one, is we've actually been doing this for a really long time. And so whereas our ability to get people vaccinated for COVID might be much different in 20 years, we're sort of on the end already of that process. The second point that I think comes to mind just off the cusp is that the gravity of overdose deaths and familial interactions, I mean, everybody in this room, I'm not going to make you raise your hand as a family member or an extended family member that probably drinks a little too much, maybe to an extent that has actually ended up affecting their health, or it was your parents or your uncles, your grandparents. And this stuff creates a type of harm that is a little different than how COVID affected the general population. I think a lot of arguments from the anti-vax community is that they see, okay, I got COVID, I wasn't that sick. What do you mean I need a vaccine, right? But I saw my dad, pass out on the floor every night for 20 years. That's a different kind of experience. And so the second point that I think I'm making here is that the impact of addiction on the community is a little bit more intense, I'm going to be honest, even than COVID was for the past 2 years, because it's affected our entire civilization, our entire nation for thousands of years. I mean, this goes back to Prohibition in the late 1920s. I mean, we've been fighting this battle for a really long time. And so that's the second point. And then the last point, I think, is that the science of literally just looking at a brain scan is a little bit different than having to convince someone that at the molecular level we're messing with their DNA. If I'm literally saying, here's a pretty picture of a brain, do you see how the blue is now red? like that might be a little easier for someone who doesn't believe in any kind of science to say, oh, okay, maybe I can buy on to that. And so will there ever be a world where science is just off the cusp, completely believed? No. There's going to be a population that will fight against this. And like Steve was saying at the beginning, they're never going to grow from this idea of lock them up. But I think the fact that we have the symposium here and the fact that even Congress is passing bills like Annie was alluding to means that we're actually winning this war right now against people who might not believe it. So.
Thank you. Any other comments?
Sure, yeah. Thank you for the question. And if you didn't hear it, it's basically there's a lot of people who don't believe in the science of substance use disorder as a disease. How are they ever going to buy this? That treatment may work better than incarceration. And one thing that always, we all believe in money, right? And it that really can tug at the purse strings of someone. It costs a lot less money to treat someone for substance use disorder than it does to incarcerate them. I've written policy briefs on opioid use disorder overdose, specifically in Missouri, and just the amount of the sheer volume of money that we spend on reversing or treating opioid overdoses in emergency rooms is in the tens of millions of dollars. That's outside of the carceral system. So to warehouse someone for weeks, months, years because of this disease costs a lot more. So if they don't believe in science, like they will maybe be like, oh, well, maybe this will cost me less money in taxes and whatnot. I find that money is always a good thing to bring up too.
Very good. Thank you. Any other questions? There we go.
Good morning. I wanted to address a little bit about the difference over the last couple of years between the opioid conversation and race, okay? And how that, and is that included in any studies? Because I know today we would highlight and lift up the substance use disorder question and the opioid issue, that it's a treatment issue. And I agree with that it should be treated because you can't incarcerate an addiction. I get that. But where was the conversation when the crime was crack cocaine, right? And so if you're white and you're opioid addiction, you need treatment, and we need to help with that treatment. If you're an African American, you're a drug addict, and you need to go to jail. Yeah. So has that been incorporated into the study about the racial equity, I guess, along that conversation?
I can answer that. I know in Johnson County that we've looked at it in the juvenile level and disparity, minority contacts. And there was a few strategies that we talked about that sometimes were causing us to have some different outcomes. And that had to do with economic, really, bases. Yeah, and so we addressed that at the juvenile court level. And it's funny that you brought it up because the Criminal Justice Advisory Council in Johnson County, we're going to take what we did in the juvenile side and apply it to the adult side and look at that very thing, because sometimes it's not intentional, but sometimes it's unintentional differences, and it could be little things that cause us to have different outcomes. And so I look forward to the work that we're going to be doing to try to determine if we are doing it the right way to be fair to all people.
And I think you're exactly right around the poverty issue, because that causes more people who are actually in prison because they said that African Americans and white people commit crimes at about the same rate. but you can't tell that any day in a courtroom, right? So, but if you have money and you can afford a lawyer, you don't go to jail, right?
Yeah, and I will say that that's one of the things that our system has really tried to do is take away the money side to make sure that that is not an impediment to outcomes and also opportunities.
Yes, see if I can figure out a good way to come back at this. I'm thinking of the medical side, and I do know people who have the opioid addiction. Probably a doctor started it and or pain, whatever. But then that person wants to get treatment because they are having problems and maybe they've already broke the law and they're not in jail yet, but they're in the system. And the problem I've seen with people that I'm connected with is that the treatment in clinics is limited. A lot of clinics will not taper people down off opioids. They want to cut them off. They don't allow methadone to be used as part of the treatment. And how do we get that changed in our states to go down to allow more clinics to not be liable for treatments in their clinics? Because a lot of people want to go to their doctor and they do want to be tapered down, but they can't get the help there because their clinic does not allow methadone to be dispensed. So I see there's another side of this, and money. If you've got money and you need treatment, you can get in, you can find a bed. If you don't have money, a lot of times you cannot find a bed or help. So that's my question on the other end. How do we get treatment before this person is incarcerated and gets cut off from treatment? And different states are different, of course. But do we go to the legislative level? How do we get the clinics to say, yes, we will have a taper off program that we will stand behind, that we will not be liable for a person? I think they're all worried about, getting sued or something. But so on that end of it, how do we wake the clinics up to help people with opioid abuse to start the process then? So they're not searching all over. A lot of them can't drive because they've maybe lost their license. They can't go to the $100 an hour psychiatrist, whatever. So that's my question.
Yeah, thank you, Teresa. Again, what we keep kind of banging our heads against the wall about is that, gosh, we have so many resources and really organized ways of treating those addiction issues in the prison. It's like they shouldn't have to come to prison to get that. And I know, speaking as a nurse practitioner, being a nurse practitioner alone doesn't allow you to prescribe any of those treatments, Suboxone or methadone. We have to apply and take classes to get an X waiver that can allow us to prescribe those medications. So that's the first barrier. And it's not necessarily wrong. It's appropriate for us to have that education in order to prescribe it appropriately and safely. But on top of that, this was one change that recently happened, and this was through, I think, the SAMHSA, I think, that when you first started your first year of having an X waiver, they used to have a limit of how many patients you could prescribe to, and it was 30, which is like a month of prescribing Suboxone and methadone, and that was recently lifted to 100 patients. And for physicians, it's different. I think they have a fairly there's not a whole lot of limits to how many they can prescribe to, but there's a lot of layers to that in terms of the barriers and how many people we can prescribe to and what we have to do in order to get to that point. Not to mention the clinics themselves have whether or not they can apply to be an outpatient treatment facility and that type of a thing. So I would say that a lot of it is talking to your legislators and making sure that your states do not have those specific barriers that are holding us back from providing more treatment to more patients. Specifically in our department, we're in the process of changing our clinical standards or clinical policies to make it easier for us to give Suboxone to patients. Numbers-wise, I can tell you we have more than 1,200 patients with a medical diagnosis of an opioid use disorder, but we only have 220 in the MAP program. And that's simply because there's not enough providers to prescribe Suboxone. There's not enough nursing staff to administer the Suboxone. And so we're working just within our department to break down those barriers and make it easier and streamline the process of not only prescribing, but simply administering Suboxone and methadones to our patients. So that's definitely something that we need to stay on top of, and making sure those processes are easier and affordable.
Thank you. Thank you very much. And thank you again for giving us this opportunity. Thank you, wonderful panelists. And we're going to turn it over to the next panel now. Artie, great.
Wow. Thank you all. Thank you. Mike, Keith, Chris, Annie, Andy, and Steve, and Michelle, thank you very much. A lot of good information there. One of the things that stood out to me was, think for just a moment, if there's 65% of the people in prison that experience some type of substance use disorder, which is a medical diagnosis, and yet they're in prison, think of the space that we could free up in our prisons by being able to get them treatment versus punishment. And think of the help that they will be able to get being treated rather than punished for what they've done. And think of how that would change our criminal justice system and change the lives of the people affected by this substance use disorder by treating them with dignity for the medical condition that they have. Be a huge change for our system. I want to encourage you to use social media today. If you are as inept at social media as I am, you might need to talk to one of the people in the back of the room to help. But we have a hashtag Courage to Change, hashtag ROFW 2020, not 2022, because this was supposed to happen back then, and at Reaching Out From. And I don't know what any of those mean, but Richard could probably help us in the back of the room. All right? We'll take a 10-minute break and be back in 10 minutes. Thank you.